Okay, good
Okay.
morning. Assalamu alaikum. Good morning. Today is our abdominal radiology, which is the last common session in radiology. And it is not long, it's short presentation. So this is the most imaging modalities commonly used in abdominal pathology, like plain radiograph, which is the most less sophisticated plain radiograph modality. And we have also barium studies as well as ultrasound and CT scan. So plain radiograph, you should know the indication for each abdominal radiograph for in abdominal pathology, and what is the indication and what is the I mean when to choose erect against supine or when to choose the other alternative films. So erect chest is a film which is the best to show free air under the diaphragm. So if you have a patient with abdominal pain and you are suspecting bowel perforation or peptic ulcer perforation, so and your patient can stand and you can perform the erect chest radiograph. So this is the best chest. It is the best brain radiograph to show air under the diaphragm. Patient will stand for 6 to 8 minutes. Then they will take the X-ray. So a small amount of air it will be obviously seen under the diaphragm. So erect chest radiograph is indicated in case of free air under the diaphragm or free intraabdominal gas. And supine abdominal radiograph is the best brain radiograph for all cross for all abdominal pathology. So best for the abdominal detail, it will show all the organs as a soft tissue density of the organs, and it will show also the distribution of the abdominal gas. And normally abdominal gas we should be only within the bowels, not outside the bowels. And also if there is a dilated bowel loop, you can judge on the diameter or the caliber of the bowel as well as the type of mucosa pattern there. What is it? Is it valvular conventus, which is white band crossing the whole width of the dilated bowel loop, or hostra, which is the white band crossing only 1/3 of the dilated bowel loop. Then if there is any displacement of the bowel loops by any soft tissue mass, and soft tissue mass can arise from any organs of the abdomen or pelvis, which is going to displace the bowel shadow, so easily can be seen in supine abdominal, as well as sometimes displacement of the bowel loops from the fluid, like in case of ascites. So we can see the displacement of the bowels in the easily can be seen. Okay, if there is any displacement of the bowel loops by the fluid in case of ascites, as well as we can see if there is any calcifications, easily can be seen in supine abdominal. So supine abdominal is the most commonly requested for abdominal pathology, and you will come across all the time whenever you have any gross abdominal pathology. And erect abdominal radiograph is you can order it along with the supine abdominal radiograph, for example, for intestinal obstruction, or for example, with a large or small bowel obstruction, or maybe cecal or sigmoid volvulus, we can order it. So to see the air fluid levels, so we can see multiple air fluid levels with step ladder appearance. Lateral decubitus, it will be like alternate left lateral decubitus. What mean by left lateral decubitus? Can you anyone tell me? Anas, can you tell me what you mean by left lateral decubitus abdomen?
Yes, when the patient
Left lateral
lying,
decubitus. Uh-huh.
sorry, when the patient lying at the side,
Side. Which
to
side?
check for fluid levels in the peritoneum.
Which side down? Which is the side down?
Left side down.
Why left side down? Why I didn't ask for right lateral decubitus? Why left lateral decubitus abdomen?
Mm,
Michelle? Michelle?
Because on the right side there's the liver, so you would ask the patient to lie down on the left.
Why? Why?
I'm
Any
not
one
sure.
of you? Okay, so yes, who want to
Doctor,
answer?
is it because the free rising air will produce like a radio opaque on the homogeneous side of the liver? It's easier to see.
Why easier to see in the liver in the I mean, why they do the left side down, not right side down for left lateral decubitus? Why they didn't ask for right lateral decubitus? See the indication here. What is the indication here? For free air and air level. So this type of X-ray, it will be alternate for the erect cystograph or for erect abdomen where my patient cannot stand. So if I want to see air level and my patient cannot stand, supine, he'll be lying in supine position. So if he cannot stand to do erect abdomen, so we can do left lateral decubitus. So tell him left side down, and we'll X-ray and we'll take X-ray. Okay. If my patient also cannot stand for air under diaphragm, we can also do left lateral decubitus. Why left lateral decubitus? Left lateral decubitus actually is the best film to show the air under diaphragm after the erect. So erect cystograph is the first choice. If my patient cannot stand, I'll do left lateral decubitus. It will be more sensitive than supine abdominal graph. Okay, more sensitive and specific than supine abdominal graph. Okay, but if you have done patient already supine abdominal graph and you have seen the air, the signs of pneumoperitoneum like regular signs, triangular signs, football sign, no need to repeat. Okay. But in terms of specificity and sensitivity, left lateral decubitus, it comes second after erect cystograph. So left lateral decubitus is alternate to look for air under diaphragm as well as alternate to look for air fluid levels in case of intestinal obstruction if my patient cannot stand. So why left lateral decubitus, not right? Because if you see in the left side, what we do have, we have a stomach. And when in the stomach, there is air within the fundus of the stomach. So if I put right lateral decubitus, that means the right side down. So we may mistaken the air within the fundus of the stomach as a free air, So we may mistaken the air within the fundus of the stomach as a free air if we put this right side down. So that's why left side down, where the stomach down will be there. So we'll see it up there. If you see up there, the right side will be up. So if you see air there, then you can make sure there is air, free air under the free air. Okay, there is a free air. Okay, so that's why it is good to put a left lateral side down. So left lateral decubitus, which is a left side down. So that's left lateral decubitus is an alternate for erect cystograph as erect abdominal radiograph when patient cannot stand. Then this is the most common indication for abdominal radiograph. There are so many indications. And just to see for case bowel obstruction, and where you show abnormal gas distribution and free air in case of pneumoperitoneum, and we have to see it abscess, abnormal gas pattern, calculi, or abnormal intra-abdominal calcification, and if there is any foreign bodies and other indications. So this is whenever I have supine abdominal, whenever I have abdominal radiograph, I have to know what type of radiograph. Is it supine or erect? So normally you come with supine all the time. But in case of intestinal obstruction like this one, small bowel obstruction, so they do both. They do supine as well as the erect. So in erect, always you'll have multiple air fluid levels. You'll see multiple air fluid levels with step ladder appearance. So there are multiple air fluid levels with step ladder appearance. Looks like step ladder appearance. Okay, so you can see it's like step ladder appearance. So when you see multiple air fluid level with step ladder appearance, so that's the air and this is the fluid. Okay, this is the air and this is the fluid. So you see it as a step ladder appearance. So that is erect abdominal X-ray. But in supine abdominal graph, you see here why it's commonly indicated and why it's optimal film to see cross pathology. You can see here the entire abdomen is with dilated bowel loops. And you can, in supine film, you see here, in erect, difficult sometimes to see it nicely, clearly. But here we can see, we can measure the size, caliber, diameter, and we can see also the bowel marking easily. And we can see the distribution, whether it is centrally located or peripherally located. And we can make out many things in the supine abdominal graph. So we can see this is small bowel obstruction in supine. So I can see more than 3 cm. Centrally located, presence of host valvular conventious here. So that is easily can be make sure this is the supine abdominal graph shows a small intestinal obstruction. So all the feature of small bowel obstruction here, okay, in this film. And this is multiple air fluid with step bladder appearance, which is a feature of small bowel in erect abdominal regurg. This is some example of left lateral decubitus. So in a small bowel obstruction, we can make out if, especially if the small bowel is fluid filled and dilated. So we see string of beads or string of beers, the other name. So string of beads or string of beers is when the small bowel is dilated and fluid filled. So imagine this is the upper surface of the bowel or the upper wall, because this is the upper wall and this is the lower wall of this bowel. So it is fluid filled and the air goes up and trapped between the valvular conventus. It will be trapped between the valvular conventus. So you see like a string of beads or string of beads. This is when the small bowel is fluid filled and it is dilated, and you can see like this one in small bowel obstruction. So this is one feature of small bowel obstruction. We can see it in erect abdominal regurg or in left lateral decubitus. We can see it. Okay. And here also we can see multiple air fluid level with step bladder appearance. Also we can see it in in left lateral decubitus as an alternate for erect abdominal regurg. So we call it string of beads or string of beads. This is just because air trapped between the valvular conventus when the small bowel is dilated and fluid filled. So this is the fluid here, and this is the air trapped as air bubbles trapped between the valvular conventus. So we call it string of beads or string of beads, which is one of the sign of the small bowel obstruction. We can see it in left lateral decubitus, or we can see it in the erect abdominal regurg. So we have discussed many times during our film session and this one about the biliary regurg. So we come just a little bit here about the barium studies. Barium studies, we can see it in fluoroscopy, and we have upper GIT barium studies, and as well as lower GIT series of barium enema, like for example. So the upper GIT barium studies, we have barium swallow, barium meal, and a small bowel enema, and lower GIT series, we have barium enema. For example, this one, it is double contrast barium meal. So barium swallow normally will be done for oesophagus pathology. So if you have any any carcinoma or any achalasia or any abnormality within the barium, within the esophagus, we can therefore barium swallow. So it is mainly examination for esophagus, as well as we can judge on the gastroesophageal reflux on barium swallow. Okay, in barium swallow. Barium meal mainly for the stomach as well as for the duodenum. So it will be double contrast barium meal. So what mean by double contrast barium meal? That means positive contrast, which is the barium, negative contrast, which is the air. So we'll ask the patient to drink barium. It will outline all the stomach, but if it is single contrast, it will be entirely white. So you cannot see the detail of the fold and the rogue of the stomach. And if there is any ulcer, it's difficult sometimes to see it. Or any changes in the mucosa fold of the stomach, easily difficult to see it. Okay, that's why we see it in double contrast barium in meal. So double contrast will be positive contrast, which is the barium, and negative contrast, which is air. So we'll give the patient to drink contrast, which is the barium. Then we'll give some producing granules or liquid, which will produce gas within the stomach, and it will be distended, and it will see, you see the mucosa lining nicely, and you can see the great curvature and the lesser curvature of the stomach, as well as this is pool of contrast within the more dependent part of the stomach, which is the fundus. When the patient lying in supine position, so the most dependent part of the stomach will be the fundus. So that's why there'll be pool of contrast here. But we can see all the detail of the stomach here. So this is double contrast barium meal, and this is barium follow through, and this is an image of barium enema. So for example, here in this double contrast barium enema, double contrast barium meal, and this is single contrast barium meal. So what we see here, we can make out the ulcer here. So you can see ulcer will be hole within the mucosal layer of the stomach, and when there is a hole there and ulcer, there'll be pool of contrast goes to the ulcer area, so we can make out here. And in this one, we can see it is in the second part of the duodenum already ulcer here. So there is a narrowing, you can see, as well as there is ulcer area here within the second part of the duodenum. So easily can be seen. Sometimes also barium meal, which is double contrast barium meal, it can make out what type of ulcer, whether it is benign ulcer or malignant ulcer. How we see, when we see the mucosa fold radiating cylinder and thin toward the ulcer area, so that means if in case it is double contrast barium meal. So if I see the mucosa fold radiating cylinder and thin toward the ulcer area, so it is benign ulcer. But if I see the mucosa fold is thick and regular and radiating toward the surrounding area, so that means it is malignant ulcer. Okay, so when the mucosa fold is radiating toward the ulcer area, but it is thick and regular, so that means it is a malignant ulcer. Okay, so this is an example of barium enema here. So we can make out. What do you think? Any one of you can tell me what you see here? Any one of you can tell me what you see here? Anyone? Anyone?
It's
Yes.
diverticulum
Yes, diverticulum. How we said? Why you said diverticulum?
because there is a small pouch.
Yes. So you can see outpouching sac here. See multiple outpouching sac, and you can see it here all over these bowels. Outpouching sac, multiple outpouching sac. So this is diverticulosis. And what we see here, what do you think? What is the abnormality in this one? Any abnormality here? So you can see here, this is a normal caliber of this bowel and this bowel here, but you can see here something here. This short segment of structure here, and it is like umbilical appearance with shouldering. You can see this is a shouldering here, and there is narrow. See, this is normal lumen of the bowel, but here at this section, you see short segment of structure with umbilical appearance with shouldering. This is because when there is a carcinoma, it will cause circumferential wall thickening of the bowel loop, which is involved. So there'll be circumferential wall thickening leading to small or short structure with umbilical appearance and shouldering. So this is double contrast barium enema. So this is just colon carcinoma, and this is diverticulosis. So this is one of the indication for barium enema. So barium enema, it is the best examination to show if there is any pathology within the large bowel, whether diverticulosis, carcinoma, and other diseases. Okay. So same thing here, another picture for CA colon, which is a short segment of the at the descending colon here, as well as there is a diverticulosis also here. So these multiple diverticulosis, we can see it here. So it is easily can be make and one of the predisposing factor to colon CA. Okay, for the colon CA. Okay, can you tell me what is the pathology here? What is the difference? Okay, this is the normal film and this is the abnormal film. Any one of you can tell me what is the pathology here? Anyone can tell me what is the pathology here?
There's Hostra.
Yes, there's Hostra here. What about here? Do you have Hostra here? What is the pathology here? All of you pay attention here. All of you see. This is the descending colon. This is the descending colon. What is the difference between this and this one? Just compare to the opposite side. You can see here normal caliber with normal hostration. Okay. So what you see here, you can make out this is normal caliber with normal hostration, but here is lost the hostration, and it's, you can see how, what we call this one, we call it lead pipe appearance. Lead pipe appearance in which condition? Lead pipe colon. You heard about this terminology, lead pipe colon. So you can see this normal caliber with normal hostration, but here is no more hostration. So this shortening of the colon secondary to the fibrosis, and there is a loss of hostration. So this is in case of ulcerative colitis. So this is one of the feature of ulcerative colitis in double contrast barium enema, where there will be loss of hostration and there is shortening of the colon secondary to the fibrosis, compared to the normal bowel hair or normal to this bowel hair. Okay, we can see the difference. So also other things, we can see the other feature like ulcers, like all this of ulcerative colitis. This is another one, which is, you can see this single contrast barium enema, which I can see normal caliber, then short segment of stricture, then normal caliber, then short segment of stricture, then normal caliber, then short segment, normal caliber, and the short segment. So what we call this one? We call it discontinuous lesion of the bowel, which is skip lesions, which we can see it also in Crohn's disease. So this is some most common disease in large bowel, which can be diagnosed by doing barium enema, whether single contrast barium enema, that means only barium, or double contrast barium enema, which there is a barium as well as we pump air inside the large bowel. So so that's the indication for barium enema. Okay, now we come to the ultrasound. Ultrasound is a very good tool to do for some indications, because there is no radiation dose to the patients, and it is one of the safest. It is safest modality to start with. And if I can reach to my diagnosis by doing ultrasound, so the ultrasound is the initial investigation tool for me. So ultrasound is very good in abdominal pathology to evaluate the solid organs such as the liver, pancreas, spleen, kidneys, and fluid-filled structures such as a gallbladder or urinary bladder. But you should know how to prepare your patient for ultrasound. So if you have a patient for ultrasound of the abdomen or pelvis, abdomen, so you want to scan abdomen, and definitely when you want to scan the abdomen, you have to scan the gallbladder as well as the liver. So patient should be fasting minimum 6 hours. Fasting is must. Because if the patient is not fasting, the gallbladder will be collapsed. So you cannot assess the gallbladder whether there is any stones or cholecystitis, so it cannot be seen. Okay, so that's why whenever you have abdominal ultrasound or hepatobiliary system ultrasound, so your patient should be fasting. And then after that, if you want to do ultrasound for the urinary tract system, definitely patient should be having his bladder full. So to measure the bladder, as well as to measure if there is any gallbladder stone, or to see if there is any cystitis. There is a technique of the wall of the gallbladder, sorry, of the urinary bladder. So that's why whenever you want to KUB ultrasound, kidney, ureter, and bladder, the bladder should be full. So we ask the patient to drink water before he goes to the ultrasound room, and not to pass urine, and the bladder will be full, so we can scan the bladder. As well as if you want to do ultrasound for the pelvis, the bladder should be full. Why? Because when the bladder is full, it acts like a window through which you can see the deep structures of the pelvis, because the water, it will not stop the ultrasound wave, so you can go through and you can see nicely, clearly the small structure of the pelvis, like prostate or like ovaries or uterus in case of female. That's why whenever you have an ultrasound for the pelvis, it is advisable to ask the patient to drink water. So it is very good to decide whether it is cystic or complex structure or solid by doing ultrasound. Then it is of value for evaluating non-palpable or intra-abdominal and retroperitoneal masses, and small amount of fluid collection in the peritoneal spaces are easily seen. So if you have motor vehicle accident, they may start in big hospitals. They have small ultrasound in the emergency department there, so they will do ultrasound for the abdomen to see if there is any free fluid. So if they see free fluid in the potential spaces like Morrison Botch or Lister sac, so that indicates maybe there is a damage to the or injury to the one of the solid organs of the abdomen, either liver or kidney or spleen. So that's why they have to do another investigation like a CT scan. They have to ask for CT scan, which is, it will show the more detail if there is any laceration. So CT ultrasound also, you should know what is the disadvantage of ultrasound. You cannot scan the gas, you cannot scan the bone. So if you have patient with the small bowel obstruction or large bowel obstruction, difficult to see the deep structure because of the gas. If you have patient with pneumoperitoneum or if you're intraabdominal gas, definitely it will be very difficult to scan it. Okay, it will be very difficult to scan. So this is some example of liver scan. So this is just, you can see in longitudinal for the liver as well as the gallbladder. So you can see the wall of the gallbladder is thin and not thickened, and there is no stone. And this is in transverse section of the gallbladder here. Same thing, this is a normal echo texture of the liver with the echogenicity of the portal vein. And this is some example of the gallstones, which you'll see with the posterior shadowing and multiple gallstones within the gallbladder here. This is one large gallstones at the neck of the gallbladder, impacted the neck of the gallbladder, causing the thickening of the wall of the gallbladder here, indicating there is a cholecystitis with big gallstones here. So there'll be thickening of the gallbladder wall, and sometimes also you'll see pre-cholestic fluid also due to the inflammation. So ultrasound is the best modality to diagnose gallstones. Okay, some condition we can do it by doing ultrasound. There is no radiation dose to the patients, and it is easily available and not expensive machine. And the most important, there is no radiation dose to the patients. Sometimes you may see in trauma case and trauma center or in the motor vehicle accident center or in the hospital, big hospitals in the emergency. There you see some small ultrasound. We call it focus fast. We call it focus abdominal sonography for trauma. This is just to show you, I told you, free fluid in the potential space like this one in Morrison pouch between the right kidney and the liver. So normally it should be like this one. See, you can see the echogenicity here, increase in the echogenicity. But when there is a fluid is black, so you can see the density of the fluid between the right kidney and the liver. So immediately we ask for CT scan, because this could be due to laceration of the liver or laceration of the kidney or anything. Okay, so we have to do CT scan for further evaluation. Okay, so CT scan, first of all, you should know how to prepare your patient for CT scan whenever you have CT scan, and CT abdomen always will be carried with contrast, which is like 150 cc of contrast. So first of all, we should make sure this patient is not diabetic, sorry, he's not asthmatic, or he's having any allergy, like allergy to medication or to food or anything. So whenever your patient is asthmatic or allergy, we have to cover him with steroids, which is 40 milligram, 12 hours before the examination, another 40 milligram, 2 hours before the examination to cover him, okay? And we have to monitor the patient. Then secondly, patient should be fasting before do any CT scan with contrast. And then also we have to explain the procedure to the patient in detail regarding radiation dose and everything, what is going to do for the patient. Then they take the consent for the patient. Then we have to also to check the urea and creatinine should be within normal limit, okay? Because we are giving 150 cc of contrast, which will be filtered by the kidney and excreted out by the kidney. So patient should not be having the risk groups or risk factors for contrast, which is like renal impairment, hepatic failure, cardiac failure, goiter, because this is iodine contrast, iodine-based contrast, thyrotoxicosis, any thyroid diseases. And we have to wait the outcome of this examination with the risk of the contrast, okay? So if there is no other alternative and it is going to help the patient, so we have to do it, but we have to cover with the steroid if he's asthmatic or his allergy, and we have to do the safest one of contrast for these patients. So the indication, it is powerful magnetic imaging techniques to evaluating the abdominal wall, intraperitoneal and retroperitoneal spaces, and all organ system and potential spaces. So it is the best to evaluate the masses within the abdomen. If you have any solid organs abdomen masses, with a liver mass, kidney mass, pancreas mass, anything, any mass from the abdominal organs or pelvis, CT is the best. But there is specific protocols. Pay attention whenever you have patient like you are suspecting liver carcinoma, for example, from the other examination, from the signs and symptoms, and you are suspecting, so you write it in your request, so they'll do for face liver. There is specific protocol for the liver, for the adrenal, for the pancreas, for the kidneys. So whenever you are suspecting tumors, please you write whatever there and why you are suspecting, if there is any other indicators, or if there is any examination or any blood analysis have been done, or this known case of this tumor. So you write it in your request, so they'll do the specific protocol so that you can have a good evaluation for that patient. Otherwise, they will do CT abdomen, which is only done in the portal phase, and sometimes small tumors can be missed in these organs. So that's why you have to be specific in your request. So it is the best to show the masses, and we can make out whether the mass is localized within that organs or already invading the adjacent structures, and is there any distant metastasis to the lymph nodes, to the liver, to other organs, to the bones. We can see it in the CT scan. So CT is the best to show the tumor as well as to stage the tumor and to plan your further management, whether chemotherapy, radiotherapy, local excision. Okay, so all depends on the staging by CT scan with contrast. So that's why CT is a very good tool, and the CT is the best modality to show the normal anatomy of the abdominal organs. So you can see all the detail of the abdomen, all the organs, and the deep structures easily can be seen in CT scan with high resolution compared to the ultrasound, which sometimes cannot be seen due to the bowel shadow. Okay, so CT is the best to show all the detail of the abdomen and the anatomy. And when you go to CT scan room, you'll see the anatomy of the abdomen nicely, easily can be seen in CT scan of the abdomen. So can be also differentiate between the solid and cystic masses or exudate and transudate if there is there, because we can do the reading by CT scan to know to differentiate between the exudate and transudate, and can demonstrate if there is any calcification within the mass. And for abdominal trauma, definitely is the best. So you can see the laceration and involving what segment of the liver, what lobe of the liver, and we can make out whether it is involving any blood of vessels and there is oozing or hemorrhage. So we can see easily and we can stage it. So you can see this normal liver with contrast enhanced CT abdomen. So you can see the normal enhancement of the liver with this IVC, and this is aorta, and this is the starting of the right kidney, and this is the starting of the left kidney, and this is the spleen, and this is a part of the stomach here. So when we go down, we can see that hilum, the liver of hilum of the both kidneys. We can see the right and left kidney, and we can see the remaining of the right lobe of the liver here, and starting seeing a little bit of the pancreas here, and you still see the spleen here and the transverse colon here. So this is another little bit down, and we have this is the psoas muscle, and this is the cecum here, and we have definitely all the sections. And the beauty of CT scan, we can see it in this sagittal or in axial section first, and we can see it in coronal and sagittal. So some in 3 dimensions. So if there is any tumor, we can take the measurement, the extension, and the relation to the other organs easily can be seen in the 3 dimension. And we can take the size and the extension and involvement of the adjacent structure easily can be seen in CT scan. And CT scan of the abdomen, we give oral contrast to outline the stomach and the duodenum and the small bowel and the large bowel. We give IV contrast. In IV contrast, it will enhance all the organs and blood vessels, so it will enhance the organs like spleen, the kidney. And if you see this without contrast, it will be dull. But this one in well enhanced, which is enhanced because of the IV contrast. So IV contrast will enhance the organs and the blood vessels as well as the wall of the bowels. Oral contrast will enhance the stomach and the duodenum and the small bowels and the large bowels. Then when we want to scan the pelvis as well, sometimes many times it will be both abdomen and pelvis done together. So we can give rectal contrast. So there are 3 contrasts using for abdomen and pelvis if you want to scan pelvis. So normally abdomen CT will do oral contrast and IV contrast. But if you want to scan the pelvis, we can add rectal contrast. So that so that's why you should prepare our patient to the contrast CT abdomen. So we see the liver here, how it looks, homogeneously seen, smooth outlining, and you can see in this condition what we see here. So we can see there is a laceration here. So single hepatic laceration along the fissure of ligamentum teres, and this laceration commonly occur along the nature of planes of hepatic vessels or fissures. So whenever we see laceration like this one, so you can see there is already very hepatic collection here, as well as you can see there is already collection in the Lister sac here. So easily can be seen the hematoma here, and with the laceration can be easily seen. So mainly we have to check whether this laceration involving what segment, what loop, if it is involving the capsule, is there any already collection outside the liver? So we have to make sure. And this is multi-focal right loop hepatic loop laceration with the focus of active hemorrhage. You can see because we give contrast, and when the contrast goes outside because of there is the active hemorrhage, so you see there is a brightness within the laceration here, and you can see there is a very hepatic hematoma already here. Then we see all the liver, and we scan all the liver, and we see what segment of the liver is damaged, And is it involving of the blood vessels, major blood vessels of the liver? Is there any laceration to the other organs of the abdomen? So then we can stage it, then we can send our staging to the surgeon, and they can plan our further management. So CT scan is one of the best modality to show the detail of the abdomen if there is any laceration or injury to the solid organs, especially in trauma cases. So normally when they receive the trauma cases, they will do assessment by doing physical examination and sometimes ultrasound. Then if this patient is deteriorating and they do have some signs and symptoms of solid organs injuries, 100% they will risk for CT abdomen to see if there is any injury to the solid organs. Okay, now we come to acute appendicitis. So acute appendicitis, this is the pain radiograph for acute appendicitis. So what we see here. So normally it will be seen localized ileus in the right iliac fossa. So what I mean by localized ileus or sentinel loop? So localized ileus or sentinel loop means there'll be segmental dilation of bowel loop adjacent to the inflammation. Okay, means there is segmental dilation of bowel loop adjacent to inflammation. So you can see this segmental dilation of bowel loop, not the entire bowel loop, only segment dilatation of the bowel loop adjacent to the inflammation because there is acute appendicitis. So that bowel adjacent to the appendicitis, it will be segmentally dilated. So that's localized ileus or sentinel loop. Then obliteration of the psoas muscle margin due to the inflammation there. So the psoas muscle we have on the right and the left. So there'll be obliteration of the psoas margin. Then sometimes you may see radio-opaque appendicolite, which is like this one, appendicolite or appendicolite here, which is this calcification within the lumen of the appendix, leading to the acute appendicitis. So it will be leading to obstruction to the appendix, leading to acute appendicitis, and this is due to calcification or within the lumen of the appendix. And sometimes you may see like water density mass and absence of intestinal gas in that area. So you can see here the bowel should be a little bit displaced, a little bit there inside, to the left side. Sometimes you may see like soft tissue dance there, and with abnormal gas collection, small dot or small collection of air. So that means indicating maybe there is a perforation. So we need immediately intervention, okay, surgery. So this is the most common feature of acute appendicitis in plain radiograph. But we can order for ultrasound. Ultrasound is very useful to diagnose acute appendicitis, especially in children or in very thin patients. So depends. Sometimes you may do CT scan or you may do ultrasound. Depends on the condition of the patient. So if you see child, very thin patient, start with the ultrasound because there is no addition dose to the patient. And if you see patient immobile, is not cooperative, and is very thick, so you can do CT scan. Because this needs cooperation of the patient, and thin body and children easily can be seen in the deep structures of the abdomen. And appendix, as you know, it is small structures, so sometimes in very thick patient and fat patient and uncooperative patients, difficult to see it. Okay, so you may start with the ultrasound because you don't want to go for radiation, and later on you can justify to ask for CT scan. Okay, but if patient very thick and very fat and he's not cooperative and also is so you can ask for a CT scan. So this is the indication. This is the picture of the ultrasound of the appendix. You can see this blind lobe of bowel here. So blinded lobe of bowel here. So that means it is not ileum. Okay, so ileum you can follow it all the way. But when you see like blind-ended structure, so it is appendix. And you can see the already inflammation and fluid within the wall of the appendix here, and it is thickened. And when we compress the probe over the appendix, it will not be compressible. So it will not be compressible, okay? And this is in transverse and it's in longitudinal. So you can see the layer of the fluid within the wall of the appendix, and it is thickened, and here it is thickened and more than 7 mm. So indicating acute appendicitis. So ultrasound is the safest one to diagnose acute appendicitis, but depends on the condition of the patient. It should be cooperative, thin, child, and woman also. It's good to do an ultrasound because you don't want to give radiation dose to the patient, especially we don't know whether she's pregnant or not. But if you cannot see it, but still persistent with the signs and symptoms of acute appendicitis, they can proceed to the CT scan. CT scan, it will show all the detail and which will show also if there is any complication due to acute appendicitis. If there is any collection, abscess, we can see it in CT scan. So CT scan, it's good to look for acute appendicitis, 90% diagnostic accuracy, and with good contrast, it can be filling of the terminal ileum and the cecum because we give oral contrast. Then tubular structure 4 mm to 20 mm in diameter with the thickened wall will enhance after administration of IV contrast. So you can see it here, the hair, and sometimes cecal fluid or collection can be seen. And if there is any appendiculate, can be easily seen. So you can see some collection here, little bit already there here in this patient. So indicating also there is a complication of fluid there, collection there at the pericecal area. So CT scan will show all the detail. In acute pancreatitis, normally acute pancreatitis, you may start with ultrasound, then you may go for CT scan. But this is some features which is not specific and significant, and you cannot exclude acute pancreatitis by brain radiography. But if you have brain radiograph and you did brain radiograph and you see this picture, like you can see the entire large bowel is dilated, but at the level of splenic flexure is abruptly no more air shadow. So there is a colon cutoff sign at the splenic flexure here. So you can see the transverse colon, the ascending colon here dilated, but at the splenic flexure, no more. It is colon cutoff sign at the splenic flexure. Why? Because there is a ligament connecting the splenic flexure to the diaphragm. And when there is any acute pancreatitis, due to the inflammation, it will cause that ligament to shrink or to to stretch out the esophagus and to close the to stretch out on the at the level of the splenic flexure here, and you will close it. Okay, so that's why you can see splenic at the splenic flexure there will be colon cutoff sign. So this colon cutoff sign can be seen in the transverse colon at the splenic flexure, abruptly no more gas. So this indicating acute pancreatitis due to the inflammation here. Or sometimes paralytic ileus, or sometimes you may see also like segmental dilation bowel loop in this area, localized ileus or sentinel loop. So this is another indication. So sentinel loop, if you see it in the right hypochondrium, it may indicate acute cholecystitis. If you see it in the right iliac fossa, it may indicate acute appendicitis. If you see it, the sentinel loop or localized ileus, which is segmental dilation of bowel loop in the left upper quadrant, you may think of acute pancreatitis. Sometimes also the psoas muscle on the left side will be obscured, and left kidney sometimes shadow may displace due to the collection around the pancreas. Acute pancreatitis, better to start with the ultrasound, but as I told you, ultrasound due to the gas shadow sometimes within the bowel difficult to see it. But if we can do it, if we can diagnose it by doing ultrasound, so it will be best because there is no addition dose to the patient. So if I see what is the pathology within the pancreas, then I can start my treatment. Okay, if I see some abnormality that's indicating tumor or anything, then okay, I can ask for CT scan. So ultrasound and CT scan most precisely define the anatomic extent of the lesion, and they detect the local complication if there is anything within the pancreas. So ultrasound, it is if the pancreas is inflamed or acutely inflamed, so we can see it as an enlarged pancreas, and there will be decrease in the echogenicity of the pancreas and blurring of the borders of the or the margin of the pancreas. And sometimes you may see fluid collection like this one, fluid collection at the which looks like hypoechoic area around the pancreas. So you can see that fluid collection. So ultrasound can be used for guide aspiration and drainage procedure and for follow-up. So if I see like some abnormality within the pancreas, I did the further management. Then I did maybe I did a CT scan, I see tumor, so then or any abnormality within the pancreas, so I can do treatment. Then for follow-up, I no need to do CT scan. For follow-up, I can do ultrasound. So why? Because there is no addition to the patient, and easily and fast and easily and fast. So for monitoring or follow-up, I can do ultrasound. So CT scan definitely is the imaging of choice. for pancreatitis or particularly useful for the following. So it confirm your diagnosis, whatever you have seen in ultrasound. Then if there is any complication, it will be seen easily in the CT scan because you give contrast. Then for any interventional procedure under CT scan guidance easily can be done, whether drainage or biopsy or anything. Then it will be like diffusely increase or focally increase of the size of the pancreas, as well as there'll be a decrease in the echogenicity and of the pancreas, and sometimes also blurring of the margin of the pancreas. And fluid collection can be seen or in the distal sac, or sometimes we can see at the left pararenal space. And if there is a complication like abscess or pseudocyst, in case of acute pancreatitis, we may see it easily in CT scan. So for pseudocyst, for abscess due to the complication due to acute pancreatitis, easily can be seen in CT scan. And we can do our drainage by doing a CT scan guidance. Later on, we can follow this patient with ultrasound after we do any procedures. Cholecystitis. Cholecystitis, as I told you, the best modality is the ultrasound. Ultrasound, it can be easily seen because biliary graphs, many times the gallstones will be radiolucent, so you cannot be seen. Only in 10% you may see it in biliary graph. Okay, so that's why CT scan, ultrasound is the best modality to diagnose gallstones. But the feature of gallstones on a biliary graph, you see it like multiple gallstones, or you can see it like because gallstones are mixed stones, and you may see like laminated and faceted because they are molding with each other, and because the center is loosened due to the cholesterol, and the rim is denser because of the calcium. So you may see like laminated and laminated. That means because the rim is more denser than the center, which is loosened. And faceted because they have more than one face. They have more than one face. So you can see here, you can see 4 classifications seen in the right hypochondrium. And you have to diagnose it well, and you cannot misdiagnose it with the right kidney stones. Okay, kidney stones will be radio-opaque classification. But it is not specific and not sensitive to rule out gallstones. So in case of a biliary graph, so normally you have to do ultrasound. So ultrasound, you can see the gallstones as a radio-opaque echogenic material here, structure here, and posterior shadowing below the stones easily can be seen. And you can judge on the size of the gallbladder wall, and if whether it's thickened or not. So if it is more than 3 mm, that means thickening of the gallbladder wall. And if there is any surrounding fluid localized fluid collection, can be easily seen in an ultrasound. And also when we in ultrasound, the beauty of ultrasound, when you do ultrasound, you are interpreting, you are talking to the patient and you are asking questions and you see the reactions of the patient. So when you push the probe down on his abdomen, so if you see the reflex of the reflection, how the patient reacts. So if you see pain, so you can make out there is tenderness there, and on direct probe pressure there over that one, indicating there is inflammation of the acute due to acute cholecystitis can be easily seen. And that's why we have to be careful when we scan such conditions. So this is some example of normal gallstones. So normal gallbladder with normal wall and only bile density here. So this normal gallbladder with normal wall and content. And this is with the abnormal gallbladder with the gallstones within the gallbladder here with the posterior shadowing. So this acute cholecystitis, we can see it here. This is acute cholecystitis. Okay. So easily can be seen in ultrasound, and there is no complication to the ultrasound, and there is no side effect, and there is no relation to the patients. That's why ultrasound is the best model to start with for gallstones. Sometimes we may ask for acute cholecystitis, we may ask for CT scan to look for complications, like sometimes pericholecystic abscess. So sometimes abscess. So you can see this indicating the gallbladder here too much enlarged with surrounding fluid, and also there is some abscess here. So when there is abscess, the patient, there is a high increase of the fever of the patient, the case is deteriorating, so there is so we may suspect any abscess there or pericholecystic abscess, so we may ask for contrast CT abdomen. Okay, so to see for acute cholecystitis. So this is all about for today. Any questions? I'm going to send this one to Farah and Suvina, the lectures to you. So please, you take the attendance. Take the attendance, please. Suvina, group A. Sufina, are you with me, Sufina? Sufina? Farah?
Yes, doctor.
Sufina, are you with me? Where is Sufina? Why she's not answering? Group A, okay. So please, Group A, try from my neuroradiology to do your template for CT abdomen in this weekend. Group A. So please, you try to do your template for CT scan from my neuroradiology in this weekend. Okay, in this weekend, and later on we'll discuss on Monday on during the TBL2, and we'll add another more additional information. So please, you take the attendance, and I'll see you Group A on next Monday.
Okay, doctor.
Sofina, please inform your colleagues to do CT scan template.
Okay, doctor.
Okay, then thank you very much. I will email you this presentation to your email.
Thank you, doctor.
Thank you, doctor.
Okay, thank you.